Hello, I'm Rachel Babin from the Oncology Network, proud producers of the Oncology Journal Club podcast. We've a surprise guest for this special episode. Join Craig Underhill, Hans Prenen, and their favourite Kiwi sidekick. Yes, it's Chris Jackson from New Zealand. Whilst Eva relaxes on a European beach somewhere, the boys have taken over with a dedicated Manels episode. Papers cover unconscious bias in speaker introductions at conferences, BRCA testing in men, respectful discourse, sex differences in risk of severe adverse events, and much more. You will also hear about Gongs galore and being too male, too pale, and too stale in this week's Quick Bites. You'll find links to all of the papers, bios, and Twitter handles in the notes on our websites. For regular news and podcast updates, we invite healthcare professionals to join us at oncologynetwork.com.au. It's free and it's a fantastic way to support the OJC. We hope you enjoy listening. This is Rachel Babin, and this is the Oncology Podcast.
G'day, g'day, g'day. Or as we say, kia ora, tēnā koutou, tēnā tātou katoa.
Who's that?
My goodness. It's our second favourite Kiwi medical oncologist, Dr. Chris Jackson.
Oh, fantastic.
Kia ora. Thanks for letting me crash, guys. I found this web link lying around and I dived in, and who should I stumble across except for Manel.
So, everybody, this is a very special episode of the OJC. First time we've done this is the Manel episode. So, Eva Segalov is still on her sojourn in Europe, visiting her daughter in the UK. So we're missing you, Eva. And so we decided to do this Manel episode. So we're going to concentrate a little bit on some genitourinary papers in men, but there'll be some others as well. And so it's absolute pleasure to welcome back Dr. Christopher Jackson all the way from New Zealand. Isn't technology wonderful?
Thanks very much, team. Great to be here. I've got to say that this is the favourite Manel I've ever been on, and it's such a steam company too. It's excellent. I believe, Craig, you have some recent news about a change in your pronoun.
Oh, do we need to bring that up? Yes, we were joking that I was the only non-professor on the podcast, so I'm now a professor, so I've gone fast track from senior lecturer to Aspro to full prof at La Trobe University just recently, so in recognition for research and academic contribution. So that's really lovely. I think it's really important for those in regional Australia to get recognised for things like that, to try and inspire the next generation to come through. So there you go. So,
well, congratulations, Craig, on your rapid ascent to the heights of academic excellence. I'm pleased to take your place as the least qualified person on the panel. And also, you've given me great hope. If you can do it, anyone can.
Thanks, CJ. So, Hans, are you following this conversation, getting the accents, or?
I'm really doing my best because I have to admit that I have to concentrate a little bit more with our Dr. Kiwi speaking.
Yeah, it's a terrible accent, isn't it?
We speak a foreign language in New Zealand.
So, Hans, do you want to explain to those who don't know what a Manel is? We need to recognise that, I guess, up front.
Actually, I had to look that up as well because I knew Eva was complaining a lot about Manels, and I said, what is this? Is some kind of animal or something? But then I found out, indeed, it's a Manel. It's actually a panel full of men. So I think this is easily explained. Is there a word for that in female as well or not? Does a female exist, or is it only Manel?
I think it rarely exists, so there's probably been no name for it. So certainly in the medical world, I think it's the world's full of Manels, and people calling out Manels on social media, which is good. So as we said, Eva on holidays, we miss her, and we wanted to acknowledge up front that we now have a Manel, first time ever on the OJC.
Eva will be absolutely horrified with the fact that, given her genetic aversion to Manels, that the moment she turns her back, one forms in her absence. I think it's certainly appropriate to acknowledge that unconscious bias and gender discrimination is very prominent in medicine in general, and even in oncologic academic meetings, it's very prevalent as well. And there's a lot of work being done to call out that unconscious bias and moves to correct that, given the extraordinary contribution of our very talented female oncology leaders, of which, of course, Eva is a shining example of that. So we miss her, but whenever there's a woman who's absent, there's a much less qualified and highly overconfident male individual to step up to the plate.
Exactly. So, CJ, with that, would you be brave enough to go first with your main paper? Because that sort of segues into exactly that topic.
Yeah, well, I'm actually quite intimidated to be in the company of two professors. I think there's a movie title there, Two Professors and a Kiwi. What I wanted to talk about in today's oncology podcast was data-driven respectful discourse in the Society of Surgical Oncology meeting and some of the steps that other organisations have taken to address unconscious bias in their meetings. And just to talk about whether the existing biases that we have, both ethnicity-based and gender-based, are actually intractable or whether they can be fixed. I think many of us will know a couple of years ago at ASCO there was a paper that was presented which looked at the use of the gender differences between female and male presenters and how chairs were much more likely to introduce female speakers by their first name, much less likely to refer to their professional characteristic and their professional accomplishments, and were more likely to refer to them in such ways as my friend and the like, more feminine style introductions which underplayed their professional achievements. When female oncologists and presenters were surveyed, it was found that the female presenters preferred the use of their professional titles compared to their personal titles. And it was thought that the use of these different in ways of addressing presenters was in actual fact a form of unconscious bias that should be looked at to be addressed. And so as much as I always like to think that the surgeons perhaps less forward-thinking and advanced than medical oncologists, the paper I was going to discuss today was one from the Society of Surgical Oncology meeting. Now, this group had previously reported that professional forms of address and speaker introductions were inconsistent at their meetings and had sought to undertake surveys of speakers as to how they would like to be addressed and to do some subtle unconscious bias training along the way. They undertook surveys of speakers and asked, how would you like to be addressed? And they circulated guidelines for respectful discourse at the meeting. These guidelines for respectful discourse included things such as how did the speaker wish to be addressed, what was their title, what was their professional qualification, but also instruction to use more gender-neutral language, such as instead of using the chairman, using words like the chair, and also other language to less stigmatise discussions around patients. So, for example, instead of saying the patient progressed on therapy or the patient failed therapy, things such as the patient's cancer progressed on therapy and the like. So ways of softening the language that we use at our meetings to make it more patient-centred as well. So it was a more comprehensive look at how you might have a more respectful discourse at a meeting, which I think was an admirable aim. The key finding of the study was after the circulation of these professional forms of address, they found the proportion of speakers who were addressed by informal titles reduced from 30% prior to the intervention to under 16% after the intervention. So that translates to 70% of people being referred to by their professional title previously, going up to 84% simply by circulating some instructions to the chairs and the speakers. The interpretation of these results was that in actual fact, this unconscious bias and the use of non-patient-centred language and non-gender appropriate language is amenable to intervention and should be a new standard, in my view, for how meetings should conduct themselves. The language that we use is amenable to intervention. It's inappropriate to use titles that people don't wish to be referred to as. That's gendered pronouns or professional titles. We should be respectful of how people wish to be addressed. And I think that we should incorporate this in all of our upcoming meetings. I think certainly since I first read that paper, it's made me more attuned to the way in which my female colleagues are introduced at meetings and if their professional qualifications and titles are no longer addressed. And as a result, now at our MDT, instead of people being addressed by their names, they're now referred to by their professional title until such time as the surgeons get with the program and also lose the title of Mr.
Are they still called Misters in New Zealand, the surgeons?
Well, I think earlier this year, Craig, the Royal Australasian College of Surgeons recommended that surgeons be referred to as doctor. It's difficult to get some professionals to step back from that title. And I think that's in recognition of the fact that many female surgeons are referred to not as doctor, but as Miss or Mrs. or Ms. And that leads to many of those surgeons not being appropriately considered as professionals, but being mistaken for nurses or other allied health. And so the college had recommended that the title of Mr. be dissolved or no longer used, and to be referring to all surgeons as doctor from that point on. Many of my surgical colleagues are still very attached to their honorific, and they feel that's a title they've earned and are yet to transition to the college recommendation, whereas others have adapted it more readily. Not a problem, of course, for oncologists, and I find most of my colleagues just refer to me as idiot.
And is it something typical New Zealand, or are there any other country that you're aware of where they address? Because here in Europe, let's say, they are all called doctors. We don't never say Mr. or something. Or is it something British that came over, or where does it come from?
I think it is an English tradition. Certainly the College of Surgeons in the UK, when I worked over there, was still referring to surgeons as Mr. And when you got your middle grade exam to become on the pathway to become a surgeon, the registrars all started calling themselves Mr. And that was certainly the trend when I worked there in the mid-noughties. Not sure if that's persisted. But that certainly came from the time at which the College of Surgeons and the physicians were very separate, and the historic linkages of surgeons to their origins in the barbershop.
Oh, fantastic. So I think, maybe I will go to my main paper then, because I read, of course, as you always listen to the podcast, you know that I read a lot of Nature, GCO, all this kind of stuff. So this time I decided again to choose a GCO paper, quite recent one, February 2022. It's also about sex differences, so it's an interesting paper, and it's called Sex Differences in Risk of Severe Adverse Events in Patients Receiving Immune-Targeted or Chemotherapy. And I find it a really interesting one because it was data from more than 23,000 patients, all enrolled in more than 200 phase 2 and 3 trials. And they actually looked at differences in side effects depending on sex. And a bit maybe to a surprise, maybe not for all of you, but in general, there was a greater severity of both symptomatic adverse events as hematological adverse events, because you can say, okay, maybe some group complains more, so have more side effects, but also the hematological adverse events is something that you cannot mimic, of course. And we saw more adverse events in women across multiple treatment modalities. So not only for chemotherapy, but also immune therapy, targeted therapy. And then the next question is, of course, okay, what is the reason for that? So there are several possible reasons. Maybe there's a difference in reporting. Maybe pharmacogenomics of drug metabolism or disposition of the drug is a possibility. Maybe the total dose they receive. Maybe either men or women take more or maybe want to take more drugs than other ones. The adherence to therapy, that's also a possible explanation. But what was surprising is that there was particularly a large difference in the immunotherapy trials. It's something we already know, but we should take this maybe more into account. And I think one of the general messages in the future is that sex should be taken into account in the evaluation of risk of adverse events. And because the study team examined here in this study more than 8,000 women and 14,000 men. And as a number, 64% of patients had grade 3 side effects, and women had a 34% increased risk of severe adverse events compared with men. And in immune therapy, it was even 49% increased risk. So I think the main conclusion there is that awareness is needed of this symptom difference between men and women. And I think there's still a lot of work to do to find out what are the reasons and maybe take this more into account into clinical trials. Is this something that you already knew or not?
Oh, there's been a lot of talk as to whether, men and women have different rates of response to IO in the melanoma world for sure. We have less access to immune oncology therapies and GI cancer, which is my other main tumour type. And certainly there are, gender differences in both the etiology of colorectal cancer and long-term outcome for men and women as well as site distributions and therapies offered as well. So I think there's biological differences in the cancers. I think there's treatment differences in how people are treated as a result of their gender. So I think multiple factors are worth considering. So toxicity, as well as symptom recognition, as well as disease differences. I think people are becoming more aware of gender differences, which I think is appropriate. Recently, there was some commentary around PPE being decided for men, yet worn more by nurses. And so we have to think about these gender-based differences a lot more, really. Hans, with immune therapy, women are certainly more predisposed to autoimmune diseases than men. With the IO, was there any interaction between those sorts of more rheumatological type conditions like the RAs and the lupuses and that type of thing as well, accounting for that difference?
I think it's a possible reason, but maybe also let's say, bacteria can be different. That the whole immune system is determined by different factors. You have on one side external factors, intrinsic factors. The flora is just one of them. And I think also the way the immune system works, the role of hormonal stimuli, etc. So I think there are probably many, many, many explanations why there could be a difference between a response to immune therapy in women versus men. So I think it's a very interesting topic to study, and I feel a bit bad that I never did this exercise myself because it was already known, and it took until now, GCO 2022, to publish this data. It's something we could have looked at before, let's say, a couple of years ago.
Did anyone look at the difference was there any analysis according to parity? So, whether or not pregnancy and exposure to fetal antigens or placental antigens had any impact on that at all, Hans?
To my knowledge, it's something they didn't really look at. Also here they excluded, of course, the sex-specific cancers in this analysis because it doesn't make any sense there. Of course, you can go for breast cancer in male, but I think the numbers are too low to compare there. So I think there are still a lot of questions to be answered.
So were there any man side effects, Hans? Were there any particular or worse, like fatigue or the need to lie on the couch? Or
No, they didn't put that in detail. They just looked at the grading. So let's say they had looked at grade 3 side effects. Maybe it's an interesting one to look whether fatigue is something typically man or female within clinical trials. So, Craig, did you prepare some short bites or
a main paper even?
You even prepared a main paper. I didn't know that you read so many papers that you had a main paper. Usually you do a lot of short papers.
I'm a professor now, Hans. So,
okay. Sorry for that.
So I picked a man cancer, testicular cancer. So this is a paper, imaging modality and frequency in surveillance of stage 1 seminoma. Results from a randomized phase 3 non-inferiority trial called TRIST. So this was a group of investigators in the UK. A big shout out to Martin Hiley, who's one of the co-investigators. Martin and I were research fellows together at the Guy's Hospital in London many years ago. So it's good to see that he's still working and also publishing. Good on you, Martin. So this was a paper looking at whether it was safe to minimise some follow-up in men with stage 1 seminomas. So we know that the survival in that cancer is very good, close to 100%. And so various groups have designed follow-up programs, and our own Australian, New Zealand urological group has some suggested follow-up guidelines for stage 1 seminoma. And the standard follow-up in this study was similar. So this was a phase 3 non-inferiority factorial trial. There was 600 patients. They were split into 4 groups. One group got 7 CTs over the 5-year period, 6, 12, 18, 24, 36, 48 and 60 months. So that's the same as the ANZUP recommendation minus one of those scans at the 48-month mark. The second group had the same follow-up schedule but had 7 MRIs instead of 7 CTs. And then the other 2 experimental groups had 3 CTs or 3 MRIs at 6, 18 and 36 months. So as looked at, the primary outcome was 6-year incidence of the Royal Marsden Hospital stage, more than 2C relapse, which is greater than 5 centimetres. And secondary outcomes included relapse more than 3 centimetres, disease-free survival, overall survival, and intention to treat, and per protocol analysis. 660 patients in 35 UK centres. It took 6 years to do. Half of them were low risk, so less than 4 centimetres with no retestus invasion. And with a median follow-up of 6 years, only 12% had relapsed. more than stage 2C relapses on this Marsden scale. It was very rare. There was only 10 events, but there was 9 events in this 3-scan group versus 1 in the 7 scans, but that met the non-inferiority. So only 4 of the 9 in the 3-scan group could have been potentially detected with the 7 scans. So the non-inferiority was met. The overall survival was excellent. It was 99%. There was no tumour-related deaths. So the suggestion by these investigators was that this form of surveillance was safe, as the advanced relapse is rare, and salvage treatment is very successful with good outcomes. So it'd be interesting to see whether the experts at ANZUP will take this as a prospective randomised study. A lot of our follow-up is based on potentially a retrospective series. So this is, pretty robust data. It'd be interesting to see if the experts in the ANZUP group decide to change their follow-up schedule as a result. MRI is not freely available, but the thought there was if that could be incorporated into the CT, it saves on doses of radiation in otherwise mostly young men who have a low risk of relapse and a high chance of survival. So trying to mitigate the long-term outcome. So interesting paper.
What are the cost implications, Craig, in terms of MRI versus CT in the Australian circumstance? So would MR be cost equivalent?
That's a really good question. So we don't often think about that because often it's paid the patient's bulk bill, so there's no out-of-pocket. But for MRI, I don't think that's a reimbursed modality in this situation. So there would be out-of-pocket costs, and it might be around $1,000. But the cost to the system, I don't know what the cost to the government would be of CT versus MRI. Interesting question. I'd say that MRI is more expensive, I would say.
It seems that the data in the study certainly supports a switch and, clearly with the lower radiation exposure and the fact that you're surveilling the cured and exposing them to low-dose ionising radiation. I was interested to read that between 1.5 and 2% of all adult cancers in the US are going to be attributable to medical CT scanning in years to come.
Wow. That's a lot, isn't it, when you multiply that over a population?
It certainly is. So I think that exposure to ionising radiation does need to be minimised wherever it's unnecessary. And certainly surveilling a group who are pretty much cured anyway, you need to have a minimisation strategy so long as that doesn't lead to an increase in patient harm, right? And then you have to think of the health economics around the MR versus the CT. From a patient perspective, I think I prefer an MR to a CT, lower ionising radiation. And interestingly, the MR picked up the relapses at a smaller size than the CT, so it suggested that it had a greater sensitivity as well.
Have you ever had an MRI, CJ?
I had one on my neck when I was a junior house officer because I was getting ridiculous pain.
How did you go? I didn't think I was claustrophobic until I had to have an MRI, and I completely freaked out.
I lay there with my eyes closed.
It was like putting your head in a cave and the bear was going to bite it off or something. It was real like this primordial panic, putting your head into a box. It was awful. So I don't think they're not for everybody, are they?
Nowadays, my ego's so big I can barely fit into the MR tunnel.
Hans, what's the follow-up? Do you know stage 1 seminomas in Belgium? It's become minimal.
Yeah, because there's no standard follow-up, but we try to keep this really on a minimum, and especially because there are a lot of young patients. And as Chris said, I'm a bit surprised about the number of CT or like ionizing radiation and the relation with tumors, because I always tell my patients if they get only one scan every year or maybe 2 scans a year, this is not dangerous. But it seems that if you give it for, let's say, 10, 20 years, it might be harmful.
Yeah, that's right. There was a 2.8% relapse in the 3-scan group and 0.3.
I'm a big fan of MRI, but you have the problem of availability. It takes longer, of course, so you can scan less people. But I think also their technical things are improving, that these times get shorter and shorter. And let's hope in the future that we can completely change to MRI like we do now also for electricity cars and stop using gas.
Yeah, okay.
Well, let's be honest, surveillance in oncology doesn't add greatly to patient outcomes. And given that we're going to see a 50% increase in the number of people diagnosed with cancers it's difficult to see how we can sustain a global oncology workforce with those sorts of growing numbers. And we have to look at every possible opportunity for anywhere where we can minimise low-value healthcare so we can redirect our resource towards high-quality healthcare, which is the adjuvants and seeing those new patients and getting people onto early treatment. And follow-up has been controversial in colon cancer, which is actually curable in stage 4, and it's the most studied, and yet there's still no survival gain from an intensive surveillance schedule. And so all the other surveillance we do for stage 3 and stage 2 tumours is almost certainly adding nothing except for cost and lead time bias to our cancer system, and we need to eliminate low-value care. In testicular cancer, a highly curable cancer, that's going to be more difficult to get us to follow a less intensive schedule. But an important point from the study was that the marker follow-up and clinical examination did not diminish. This was only about the scan intensity which diminished, not the clinical follow-up of those patients. The time with clinician wouldn't necessarily reduce.
Okay, well said. Eva, if you're listening, there's an idea for another podcast special on low-value healthcare in oncology. Hans, do you have some quick bites for us?
Yeah, I selected 3 quick bites, so very snappy. One is about our favorite drug, impossible to pronounce, but we will still try it. The trastuzumab deruxtecan. So as you all read in the New England, there was a paper that comparing trastuzumab deruxtecan versus trastuzumab emtansine, so TDM1, for breast cancer. Very briefly, because we discussed it before, but now it's published. It's a phase 3 study comparing both drugs in 500 patients after a combo of anti-HER2 and taxanes. And actually, the data show that the patients alive without progression at 12 months is 76% in the ones with trastuzumab deruxtecan versus 34% in trastuzumab emtansine. So it seems that trastuzumab deruxtecan is the better drug. Of course, we have to be aware of the pneumonitis, but this already was also highlighted in previous podcasts, and it was 10% in this study in the deruxtecan group, and also surprisingly in the TDM1 group was also 2% pneumonitis. So another study published by my friends of the Netherlands in Kansas, February 2022, is a very interesting one about physical activity, because we speak a lot about screening, follow-up, using resources, MRI postoperatively, CT, but maybe just do physical activity. So we know in stage 1 to 3 colon cancer, regular physical activity is associated with improved overall survival. It's not so clear in the metastatic setting. So the Dutch colleagues looked prospectively in 300 patients, and they measured the physical activity by calculating metabolic equivalent task. I never heard about that, but it's called MET, but it's some kind of number of hours that you do some kind of activity or physical activity. And they conclude that compared to low levels, moderate and high levels of these MET hours were associated with improved survival in metastatic colon cancer. So it's something where we tell our patients, if they ask, okay, what should we do, doctor, what can we do ourselves? I always say, okay, try to live as healthy as possible, take healthy food, do a lot of sports, etc. So I think this study confirms that keeping your body in good shape also helps in a metastatic setting, at least in colon cancer, to improve survival.
Certainly, I think it's important to be able to give patients interventions which they can undertake themselves in terms of establishing their internal locus of control over their situation, and autonomy and control is so often lost in patients with metastatic disease. So giving them something they can take on themselves to lead is really critical, I think. Going back a number of years, the CALGB adjuvant studies, I think, again, look to exercise and nutrition in stage 3 colon cancer and long-term outcomes, and they use the same MET hours from memory in their adjuvant setting, and I think they found it had a similar proportional benefit as chemotherapy, about 15% in stage 3 bowel cancer. And in that study, they found that it was the high-intensity exercise or resistance-based exercise that was more potent than other forms, even when you standardise it back to the MET tasks. Did they find anything about the type of exercise that you had to undertake to get the benefit? Or when you say moderate to high, what's the threshold? What's the levels of exercise that people have to do to get the benefit?
It's a good question, Chris, because a lot of the papers in the past have been based on pretty intensive and frequent exercise.
I think it's a really good question, and of course that's why I was a bit surprised by this metabolic equivalent task hours, something I'm not familiar with. And they didn't look in detail which kind of activity was needed. So probably this is a story with multiple sides. I must say, if I wouldn't be an oncologist, I would become sport medicine or sport doctor, because it's a super interesting domain with still a lot to learn. What kind of activity you have to do to improve the health of your body or to train. You see this with cycling, etc. That the scientific insights are improving. So I hope also within cancer that maybe with just 10 minutes daily intensive activities may be enough to boost your immune system or whatever is helping improving your outcome. So I think it's a separate domain which needs to be studied more.
I think that being a sports medicine doctor would be very much like being a COVID doctor at the moment, and that is all the experts are actually online, and all you need to do is buy the supplement and you'll be absolutely and utterly fine.
My final quick bite, it's also one of my favorite drugs, or let's say group of drugs, is about targeting KRAS G12C. And that's why I want to show the data of the first in-human phase 1 trial of adagrasib. It's the drug of Mirati in patients with KRAS G12C solid tumors. It's called the Crystal-1 study. It's a very interesting study published also in GCO, February 2022. They looked into non-small cell lung cancer, colon cancer, and other tumors with KRAS G12C, 25 patients in the refractory setting. And there was actually no maximum tolerated dose, but they determined the recommended phase 2 dose at 600 milligram. And in general, there were 50% responses. Of course, responses here don't mean a lot. It's 25 patients in a heterogeneous group, but we know from the other drugs like sotorasib that we discussed before in the podcast, that probably the responses in lung cancer are higher than in colon or other tumors. But that's something we try to solve in the future by combining with other drugs. What do you think about this, Craig?
I think it's a really interesting field, isn't it, these targeted therapies, and we're probably still at the start of our knowledge, but yeah, it's exciting. And they're expensive, Chris. But Chris, do you have some advice for us?
Well, I've got some absolutely groundbreaking and life-changing retrospective observational studies to discuss.
Take it away.
I think people who've worked in academic medicine who've got teaching responsibilities will have been very aware of the arguments behind blinding of student assessment, because unconscious bias clearly has an impact on student assessment when you're looking at the marked work that's there. And also increasingly professors, well, I wouldn't know this because I'm not one, but senior lecturers graded and professors are graded according to their student satisfaction surveys. And I've read around blinded surveys of online taught courses where student satisfaction surveys are very heavily influenced by the gender of their professor or teacher. And even in one interesting experiment, the online teachers swapped their teaching whilst pretending to be the other person. So the male swapped with the female and the female swapped with the male, while the students continued to think they were of the original gender. And they found the student satisfaction scores tracked with preferences for male gender, even when it was a female teaching incognito, sort of like J.K. Rowling writing her book under a male pseudonym. And so again, that raises the spectre of student unconscious bias in teacher evaluation. And when you're tying promotion to student satisfaction, that's an important bias to take into account. Also, elsewhere in the world, physician reimbursement and patient satisfaction are being taken into account more in some healthcare systems where fee for service and pay for performance are taken into consideration. And so the question of whether or not patient preference and patient satisfaction is influenced by physician gender or other characteristics which are non-modifiable is an important question, because if there is unconscious bias, then it would be unfair to tie physician reimbursement to those characteristics. A group of radiation oncologists from the Memorial Sloan Kettering looked at bias and patient experience scores in radiation oncology and undertook a retrospective analysis. Multiple centres look at patient satisfaction surveys and a number of factors that would be common to all patients, such as wait time, for example, the type of organ cancer they had, whether they had a physician of the same or different gender, and what the gender and ethnicity of the radiation oncologist was. And very pleasingly, they found no evidence of a difference in patient satisfaction scores by patient gender, which was highly reassuring for that group. I could counter, however, that perhaps what happened was that the male mediocrity compared to the female superiority was actually falsely graded as equivalent, and that could be a different interpretation of the paper, but the paper couldn't find a difference between patient satisfaction scores and oncologist gender, which was somewhat encouraging. I think how I would interpret that paper is that we should not resist patient satisfaction as a way of evaluating physician performance, and we should be incorporating patient satisfaction scores more and more into our personal evaluations and our professional evaluations, and not be as concerned about the unconscious bias effect as perhaps some would have us. The other quick bite to review upon, I'm not sure, does Australia promote professors to the title of Sir, Craig? Can you aspire to the title of Sir Professor Craig Underhill?
I don't think so, Chris.
So you've now got rid of the Queen's honours altogether now in Australia. You can't be Sir or...
accept one from the Queen. So anyway, that's a whole other episode, but let's go through your quick bite.
We all know that the UK has an honours title, and New Zealand, as a colonial country, clings closely to what the motherland does and follows closely where she proceeds. And so a review was undertaken called Gongs, Galore, a failuristic study of the relative risk of a healing art related to New Year honour. In other words, what makes it more likely for you to become a Sir or a dame? And this study of 10 years of New Year's honours from 2010 to 2019 found that doctors were less likely than other professions to receive a New Year's honour. So if you're a doctor, you're less likely to become a Sir than other professions in the UK. But if you were a healthcare professional and got a gong, the specialty who was most likely to get a gong were public health physicians. And the second most likely to get a gong, to become a Sir or a dame, oncologists.
Really?
So there's hope yet. Oncology, second most likely to get a gong out of all medical professionals. And for the Manel, you'll be reassured that men were more likely than women to be awarded a New Year's honour. So male oncologists are more likely to be awarded New Year's honours than anaesthetists and other medical specialties, even if we're less likely than other specialties. So there's hope for us yet, men, on the Oncology podcast.
Thanks, Sir CJ. So I do my quick bites, looking at men. So I found a couple of interesting papers investigating men's motivations to engage in genetic screening for BRCA1 and BRCA2 mutations. So men generally appear to be less motivated to get some testing done. But there was correlations with having offspring, and also perceptions of self-efficacy and risk perception to want to go through with BRCA1 and BRCA2 mutations, pointing out that a lot of the research on BRCA1 testing is based on breast cancer research, and there probably needs to be more research tailored to men and some tailored interventions such as communication methods and informed decision-making tailored for men. So that was interesting. Exploration of well-being in men diagnosed with prostate cancer undergoing active surveillance, qualitative study. This was only in a small number of patients, but it showed that there was extra anxiety related to active surveillance in prostate cancer as opposed to, having curative surgery, and that spiked each time there was a visit to the oncologist. So that's not really a surprise. I think we all know that anecdotally patients on follow-up often do get stressed in the days leading up to their appointments. And so that's something just to be mindful of. And then too male, too pale, too stale, a qualitative exploration of student experience of gender bias within medical education. So again, a qualitative study, but basically pointing out that there is still gender bias and a lack of role models in medicine. So, for example, one anecdote in this paper was that students were surprised when they had a black female lecturer because they were used to seeing pale male stale lecturers. Rachel, our favourite new segment, take it away, please. The blow your own trumpet segment. CJ, this is a new segment where we get to present our own papers. So this was called Guide, a randomised non-comparative phase 2 trial of biomarker-driven intermittent docetaxel versus standard of care docetaxel in metastatic castrate-resistant prostate cancer, the clinical trial protocol published in Therapeutic Advances in Medical Oncology. So there's some quack called Craig Underhill as an author, and a big shout out to some of the other co-investigators, including in regional Australia, Florian Honeyball and Javier Torres in Shepparton, and some of the other authors included Ian Davis in Melbourne, Lisa Horvath, colleagues and friends. And so this is basically setting out the rationale behind this protocol, which is a biomarker-driven study where, according to detectable MGSTP1, so a biomarker, patients are stratified to then receive more intensive or less intensive docetaxel chemotherapy in the metastatic castrate-resistant prostate setting. So highlighting that, the importance of clinical trials. We have these new biomarkers which may guide de-escalation studies and be able and enable people to have breaks off treatment or holidays. So have a look at that paper and the protocol, and hopefully lots of people listening are investigators with ANZUP and involved in that study. If you don't have that study open in your centre, think about opening it up because it's a very common cancer, and I think very interesting, which will hopefully lead to perhaps new ways for us to use a standard treatment, docetaxel.
And that'd be absolutely great to see that going ahead, Craig. I mean, I think that, biomarker-driven chemotherapy has delivered very poorly, unfortunately. I mean, we know that UGTA1 isoforms in irinotecan didn't really take us further in colon cancer, and the HENT1 story with gemcitabine and pancreas cancer also didn't quite pan out the way we wanted it to, or ERCC1 with oxaliplatin as well. So far it's delivered very poor and disappointing results. So I really hope that this particular biomarker delivers on the promise. I mean, docetaxel, a very widely used drug with potential for high toxicity. So being able to increase delivery of that by reducing toxicity is a really important thing to do therapeutically. Are you including any minority populations such as New Zealanders in your study?
Well, I don't know. It's I'm just looking through the authorship, Chris. I think that it was all Australian authors on this paper, but presumably there will be centres in New Zealand because it is Australian-New Zealand group. I'll just note for the purposes of this Manel that the first author in this paper was Chiara Conduit and the senior author was Kate Mahon. I hope I said that correctly, Mahon. So this is like a many-year in development, the whole concept of this biomarker, the development of this protocol. So all praise to the people who have been working for many years and have finally brought this to a phase 3 cooperative group study. So let's hope that it recruits quickly and we find out whether this is a useful biomarker.
That'd be fantastic. So while we're on the topic of blowing our own trumpets, myself and Eva have been very involved in developing oral taxanes using P-glycoprotein inhibitors, and Hans was also a co-author on one of those papers with us as well. And the same technology of the PGP inhibitor to enhance gut absorption of the paclitaxel is now being trialled in docetaxel as well to try and get the bioavailability up. Docetaxel, of course, having probably a higher minimum inhibitory concentration than paclitaxel will make it a more difficult drug to model. But again, oral administration of medications has other practical advantages for patients, particularly in regional settings where travel distances are high for their IV infusions.
Okay, fantastic. Well, it's been a great episode. Thank you so much, CJ, for coming on. It's getting quite late now, I think, in your part of the world, so we really appreciate giving up your time. It's a lot of hours put in to prepare for this, and well done. Thank you for coming on. Are you going to sing for us before you go?
Me? No. I did that at Christmas. It only comes once a year.
Yeah.
And Hans, I know that you're now head of the unit, very busy schedule. So thank you for finding the time in the schedule.
It's always a pleasure, you know that.
And thanks, of course, as always, Rachel, woman who keeps us on track and gets us all organised. So thanks very much for giving us the opportunity to do this special episode. And a big hello to Eva. I hope you have you back soon.
And I know, Eva, on behalf of both Hans and Craig, they both hope you return soon because they're East Islander or New Zealander, certainly a poor substitution. So I hope you have a good holiday, Eva, and look forward to having you back soon.
Are you saying New Zealand's part of Australia now, Chris?
Well, actually, we refer to Australia as the West Island, actually. I think most Aussies would like to be... No, I won't make too many political commentaries about the quality of our respective leaders. That would be getting into politics.
For all of our listeners who are struggling to understand the New Zealand accent, we'll have a translation of this available on the link below.
Okay, that's a good idea, Craig.
Thanks, Rachel.
You've been listening to the Oncology Podcast. If you enjoyed today's edition and would like to subscribe, head over to our website, oncologynews.com.au, and sign up to our newsletter. Thanks for listening.